Greetings to all of my dear students. So in this session, the last session on anti-epileptic drugs, we are going to discuss something about prescribing guidelines and management of various types of epilepsies. So let us get into the details. So I'm going to cover this topic under the following subheadings, that is prescribing guidelines, withdrawal of anti-epileptic drugs, types of epilepsies and their treatment, resistant epilepsy management, and management of epilepsy in pregnancy and breastfeeding. So any of these things you may get short notes. Prescribing guidelines. So what are the guidelines that we need to follow while we prescribe anti-epileptic drugs to a patient? So let us see. These are all will be useful for you throughout your clinical practice. Anti-epileptic drugs can control but do not cure epilepsy in majority of the cases, I can say, not 100% cases. Okay, and some cases we can get the cure also. Complete control of symptoms may not always be possible. Anti-epileptic drugs are continued even if they prevent the seizures only partly. The primary objective of anti-convulsion therapy is to suppress seizures and provide neuroprotection by minimizing deleterious effects from seizure attacks. So if we prescribe the patient on anti-epileptic drugs, we cannot assure that 100% neuroprotection can be there. But if we don't give the treatment, the patient may have a dreadful complications because of the seizure attacks. So we need to put the patient on anti-epileptic drugs. Drugs used regularly abolish seizures completely in 60 to 80% of the patients and reduce their frequency in another 10 to 20%. So that is the incidence of net effect that we can have. Complete clinical cure may be possible in patients with petit mal epilepsy, but not all the other cases of epilepsy. So this is an advantage with petit mal epilepsy management. So what are the prescribing guidelines? Let us see. Rule out other reasons like syncope, hypoglycemia, brain tumor, hypoxia, or hypocalcemia due to primary hypoparathyroidism. All these kind of situations can give rise to epileptic manifestations or seizure attacks. So if they are due to the secondary reasons, we need to rule out the reasons, or if they are present, then we need to treat the patient with particular therapies concerned with that particular indications. Otherwise, we are not supposed to put the patient on directly on anti-epileptic drugs before ruling out these reasons. Then treat the cause first. Genetic, traumatic, metabolic, inflammatory, drug-induced or due to other withdrawal effects also may be. This may not be possible for all cases. But if at all, if you are finding out these causes, then treat the cause first. Then when to start therapy then? An anti-epileptic drug is advised if the patient has had 2 or more seizures, not with the first attack itself. But with one single seizure, we can give anti-epileptic drugs when it is. A patient who gives history of a single seizure is treated with medication if there are 1 or more risk factors for recurrence of seizures, that is like abnormal neurological finding or the presence of structural lesions or even abnormal EEG or history of partial seizures or even family history of seizures. Among all these 5 factors, if there are 1 or more than 1 risk factor is present along with the incidence of 1 single seizure attack, then you can go ahead with anti-epileptic drug therapy. Then, so you wanted to start the therapy. Then how to select the drug? Selection of drug. Initial choice of drug depends upon the type of epileptic seizure. Treatment should be started with the effective, least toxic, and convenient to take single anti-epileptic drug appropriate for the particular seizure. So every type of epilepsy has their own drugs of choice and alternate drugs. So depending upon the type of seizures, we are going to select the particular anti-epileptic drug. There is a trend to prefer the newer anti-epileptic drugs because they are less sedating. So we have discussed that in the earlier session. Produce few side effects and drug interactions are insignificant. All this, because of all these advantages, people try to prescribe newer anti-epileptic drugs, but we should not go for newer anti-epileptic drugs because they do not have long-term studies. Then monotherapy, how to give the therapy. Start with single drug in small dose, targeting lower portion of therapeutic range, then increase it gradually till the maximum benefit is obtained without an increase in adverse effects. So start low and go slow. Okay. Monotherapy with standard drugs results in satisfactory control of seizures in almost 50% of patients. Then managing ADR. Mild toxicity can be managed by reducing the dose by 25 to 30%. Most anti-epileptics produce skin rash during the first few weeks of therapy. So because of which the drugs need not to be abandoned. So you can continue the therapy. But less toxic agent is preferred. Use phenytoin if sedation is troublesome. And sodium valproate can cause weight gain and tremors. You need to keep the patient, you need to keep these points in your mind. Then avoid carbamazepine and lamotrigine if there are chances of hypersensitivity reaction. Some people may be having hypersensitivity manifestations, more prone for hypersensitivity manifestations. So you need to avoid these drugs. And carbamazepine, phenobarbital are least teratogenic. So you can take the advantage of these molecules in pregnant ladies. Then sodium valproate, most teratogenic, to be abandoned in pregnant ladies. And based on animal studies, newer drugs are also teratogenic. However, limited data are available. Avoid enzyme inducers, that is phenobarbital, phenytoin, carbamazepine, in megaloblastic anemia, osteomalacia, and women on oral contraceptives. Then hemorrhage in newborn or pregnant women may occur due to enzyme inducer anti-epileptics. These points we have discussed in the introduction and while dealing with the conventional anti-epileptic drugs also. Precaution should be taken in using newer agents. Felbamate can give rise to an area like aplastic anemia and hepatotoxicity, whereas vigabatrin can give rise to psychosis, depression, suicidal tendency, vacillation of myelin sheath, and constriction of visual fields. Vigabatrin for visual field effect. Then convenience of administration. Longer acting agents are always preferred for any disease indeed. Then phenobarbital OD or alternative therapy, phenytoin OD and carbamazepine BD, not multiple administrations. Cost, phenobarbital is the cheapest, sodium valproate is the costliest, and of course newer agents are always costlier than conventional agents. Then type of job, phenytoin may be preferred in patients who operate any kind of machinery or driving the vehicle as it lacks sedation. Sedative anti-epileptics must be avoided in such conditions. Age, sodium valproate should be avoided in children less than 2 years of age due to hepatotoxicity. And then phenobarbital should be avoided in children between 2 to 10 years as it may cause paradoxical excitement and alteration in the cognitive function. So age has to be taken criteria. So in children from 2 to 10 years, phenobarbital need to be avoided, and less than 2 years, sodium valproate because of its hepatotoxicity. Then 6, phenytoin should be avoided in young girls due to gum hypertrophy and hirsutism. That is a cosmetic problem. So don't ask me that there can't be cosmetic problem among the males, young boys like that. So it can be, but it is more prone. So like girls are more keen for the cosmetic problems. So that's why it is mentioned even the standard textbooks. So it is to be avoided in case of young girls. In women on oral contraceptives, enzyme inducer anti-epileptic drugs should be avoided as contraception failure may occur. Then special situations, in renal disease, avoid the drugs which are excreted unchanged, that is like gabapentin and topiramate. And in hepatic disease, avoid or reduce the dose of the drug which are metabolized. That is most of the anti-epileptic drugs, of course, they are metabolized through liver. Then only one through blood or plasma, that you need to remember. Avoid phenytoin in diabetes mellitus as phenytoin causes hyperglycemia, that is by inhibiting insulin release. Then counseling to the patients and patients' attendants regarding the duration of treatment and the need for compliance to keep a seizure record and to attend the follow-up clinic regularly. So regular counseling need to be done for all the chronic diseases. When to plan substitution therapy? Suppose you have prescribed the drug and it is not working. So when to plan the substitution therapy? Adequate trial for 2 to 3 months should be given to anti-epileptic drug before rejecting it in favor of another. So to say that it is a rejected therapy, you need to at least observe the patient minimum for 2 to 3 months. Epileptic seizures that initially respond to drug therapy sometimes escape from control. That is like phenobarbital, primidone, phenytoin, and carbamazepine. Escape may be due to hepatic enzyme induction. If adequate control is not achieved by a single drug in maximum tolerated doses, so we are going for start low, go slow, slowly increasing up to the maximum therapeutic level. Still, there is no response. And if compliance is good, that means patient is taking the anti-epileptic drugs regularly. And absence of any precipitating factors like sleep deprivation, febrile illness, and use of concomitant drugs also. All these factors are considered, then there is no response, then you need to think about the substitution therapy. So if this also fails, so monotherapy, then substitution therapy. That means one single drug is removed, another single drug is substituted in its place. Still there is no response, then you have to go for combined therapy. So substitution therapy, while changing from one drug to another, the first drug must be tapered off slowly because of the withdrawal effects. That is like rebound or recurrent seizures may predominate. So that is the reason we have to switch over slowly, while the second one is introduced in a gradually increasing doses. Then combination therapy. Choose combination therapy in cases of resistant epilepsy, like focal epilepsy due to an underlying structural lesion and multiple seizure types. Choose the conventional drugs acting through different mechanisms, combination therapy. So they may have added over effect. Considering their ADR and potential drug interactions, you need to be very careful. So same, any combination therapy, anywhere, whether it is antimicrobials or anti-epileptics or any other group of drugs, the principles are same. Okay. If resistance persists, then a newer drug such as gabapentin, lamotrigine, or topiramate is added. And there is no response with the conventional drugs. When a drug combination is used, each drug should be prescribed separately, not with like fixed dose combinations. So fixed dose combinations are to be avoided. Discontinuation of anti-epileptic drugs. Most patients will need treatment for their lifetime, except in petit mal epilepsy, where you can observe for 2 to 3 years and then later on switch over. Discontinuation of anti-epileptic drugs may be done if the patient is seizure-free for 2 years. So the patient is like, in some cases, the clinical therapeutic response varies from patient to patient. So what happens when to discontinue the anti-epileptic drugs means, so the patient has used anti-epileptic drugs, one patient for 5 years, one patient maybe for 10 years. So when to withdraw into both the cases? The only criteria here is if the patient being on anti-epileptic drug is seizure-free for 2 years, then you can switch over. Gradually you can taper and then make the patient free of the drug. Okay. So then withdrawal of drugs. Sudden withdrawal of an anti-epileptic drug can precipitate status epilepticus. So it has to be tapered slowly over weeks or even months. Slowly we have to switch over. TDM is not always necessary. Therapeutic drug monitoring. Routine periodic determination of the blood level of anti-epileptic drug is not necessary, except in drugs which are having low therapeutic margin and higher toxicity. That is like phenytoin, we have discussed in conventional drugs. So clinical monitoring by recording the seizure frequency and ADR is more important than TDM in the management of epilepsy. So what happens? How many seizure attacks are occurring per a day or per a week or per month? So recording the seizure frequency and ADR of that particular therapy, combination therapy or monotherapy, whatever it may be. So that is the actual indication to assess the therapeutic efficacy in that particular individual. Advise the patients to avoid alternative medicine. That is, patients should be advised to avoid using OTC formulations and drugs from alternative medicines, as some of them may contain drugs which lower seizure threshold and precipitate seizures. So that is very, very important. Then selection of drug is done mainly on the basis of efficacy, toxicity, and other factors. Treatment is continued for minimum period of 2 years. So 1 year for petit mal epilepsy, 3 to 4 years for psychomotor or grand mal epilepsy. And in case of juvenile myoclonic epilepsy, the treatment could be a lifelong treatment. So we need to give thorough counseling to the patient and patient's attendants. Patients means It is a juvenile, so obviously to the patient's parents, we need to give the counseling. Then withdrawal of AEDs. So this may be like a short question for 2 marks question for undergraduates. And I forgot to tell you regarding the newer anti-epileptic drugs. So the drugs where I have given the mnemonics and summary slides, they can be short notes for you, UGs especially. And of course, for PGs, every question can be a 10 marks question, and even the total newer anti-epileptic drugs can be a 10 marks question. Withdrawal of AEDs. Anti-seizure drugs need not be taken indefinitely. Children who are seizure-free for periods longer than 2 to 4 years while on anti-seizure medications will remain so when medications are withdrawn in 70% of cases. That's what we discussed earlier. Risk of recurrence depends on the seizure syndrome, that is like juvenile myoclonic epilepsy, most common. Withdrawal is believed to be more likely to be successful in patients with generalized epilepsy, so exhibit a single seizure type. Okay, type of epilepsy is dependent on that. Drugs are generally withdrawn slowly over 1 to 3 months period or longer. Abrupt cessation may be associated with recurrence of seizures and even a risk of status epilepticus. And physical dependence occurs with barbiturates and benzodiazepines, and so the risk of rebound seizures with abrupt withdrawal. So one is rebound seizures, another is physical dependence. Then types of epilepsies and their management. So every epilepsy type management can be a short note for UG students. Grand mal epilepsy. An epileptic should be advised to use hard pillow to prevent being smothered if an attack occurs during sleep. Otherwise, the patient may die even. Sodium valproate, 600 milligrams daily, divided into 2 doses. It can be increased every third day by 200 mg. And the usual maintenance dose can be 1 to 2 grams per day. And then carbamazepine, 200 milligrams BD or TID. And the dose should be increased gradually until seizures are controlled up to maximum level of 1200 mg reached. If seizures continue, then change over to substitution therapy, that is phenytoin sodium. So for every epilepsy, I'm going to give the summary table at the end. So at least the drug of choice and alternative drugs you need to remember. And if you can remember the dose as well, then that is excellent for UG students. Then phenobarbital is a drug of choice for grand mal epilepsy in children under the age of 5 years. So because they cannot tolerate phenytoin, as well as older children and adults also do. However, phenobarbital is known to cause behavioral disturbances in children. So this need to be noted down. Lamotrigine appears to be effective in epilepsy syndromes with mixed generalized seizures and is currently considered as monotherapy as well as adjunctive therapy. So here you can see grand mal epilepsy, sodium valproate, carbamazepine, and phenobarbital. Then lamotrigine as adjunctive therapy or alternative therapy. Then going to petit mal epilepsy, E4 ethosuximide is the drug of choice. That's what we have discussed earlier. And sodium valproate also could be drug of choice for many types of seizures. Or even ethosuximide induced tonic-clonic seizures also. Okay. Then ethosuximide 250 milligrams TID up to 1500 milligrams per day. If whether you can write the maximum tolerable dose or not, this 250 mg dose TID, if you can write up to that level, that is also very good. Then phenobarbital plus ethosuximide combination is preferred in children below 3 years in whom valproate is known to cause higher instance of fatal hepatotoxicity. So then that is contraindicated, sodium valproate. Then you can choose ethosuximide plus phenobarbital combination, and lamotrigine as the other case, it is used as an alternative drug in newly diagnosed case. Drug treatment can be withdrawn 3 to 4 years after cessation of attacks. Then febrile seizures. Certain children less than 5 years and most commonly less than 2 years are prone to develop convulsions if fever is high. What happens whenever they get fever? They'll be landing upon in seizures. But over a period of time, so this can be called a febrile seizures, but the problem is if a child is getting seizures with every attack of fever, these people, around 2 to 10% of such people may develop into, may get a kind of development of epilepsy in their later life when they become grown up into adults. So that has to be pointed out. So febrile convulsions are not associated with mental retardation, IQ, poor scholastic performance, or behavioral problems. Hence, routine prophylactic administration of anti-epileptic drugs is not warranted. So whenever a child gets febrile seizures with the first or second attack itself, you need not go for anti-epileptic drug administration because it is not having all these problems. Brief febrile seizures need only treatment of the fever, that is like tepid sponging and paracetamol administration. And if the child is normal without any other risk factors. Chronic prophylactic therapy of febrile seizures need to be done when the first seizure occurs before the age of 18 months, that is before 1.5 years. Conversion is focal, that is one-sided, one side of the body, or prolonged, that is longer than 15 minutes. Then patient has any neurological abnormality or developmental delay. If any sibling or either of the parent of the patient has epilepsy, that is family history is present, and recurrence of febrile convulsions. So any of these factors are present, then there is a risk of developing epilepsy in approximately 10% of the patients. Then you need to, if the child is suffering from febrile seizures along with the coexistence of any of these factors, risk factors, then you have to initiate anti-epileptic therapy. Drug use in intermittent diazepam, either by IV or rectal route in case of children. Best treatment for febrile convulsions is rectal diazepam in case of children because they will be comfortable with that at the onset of convulsions. So they generally stop in 5 minutes. If there is no response, repeat it 12 hourly for 4 doses. Fever is prolonged, a gap of 24 to 48 hours. So 1 or 2 day gap is given, and then again series of doses. Like that, again 4 more doses can be given. IV preparation can be used when the rectal formulation is not available. Otherwise, rectal diazepam is preferred. So you may be asked in YOC, rectal administration of what drugs and for what indications. So you go back to the general pharmacology, then you can recollect all the questions. Then sodium valproate or phenobarbital can be used as alternative in case of not responding to diazepam. So phenobarbital 3 to 4 milligrams per kg per day. Otherwise, rectal diazepam, otherwise IV diazepam is the drug of choice for febrile seizures. If no response, sodium valproate and phenobarbital. Chronic prophylaxis with phenobarbital advocated earlier has been abandoned because of poor efficacy and behavioral side effects. So this is also not advisable now. So carbamazepine is another alternative. Phenytoin is not well tolerated by small children, and valproate is more toxic at this stage. So all these other drugs are not advisable. So only best alternative is carbamazepine. Child should be treated for 2 years or for 1 year after the last seizure, whichever is longer. Then, so we have discussed grand mal epilepsy, petit mal epilepsy, and then febrile seizures. Then coming to the last one, that is status epilepticus among the main epileptic conditions. Status epilepticus is clinically defined as convulsive seizures lasting for more than 15 minutes or rapidly recurring seizures without return of full consciousness between the seizure attacks. The patient will be losing the consciousness, no gain of consciousness in between the attacks, and each attack lasts for 15 minutes or more than even 15 minutes. So emergency medication is needed to prevent death or permanent brain damage. If there is no treatment given immediately, so brain damage can occur, even the patient may even die also because of hippocampal sclerosis. So status epilepticus occurs in epileptics, but may also occur in patients with other disorders such as brain tumor or meningitis or in alcoholics. Status epilepticus presents in several forms. So there are various forms of status epilepticus. That is, one is convulsive status epilepticus, that is repeated generalized tonic-clonic seizures with persistent post-ictal depression of neurologic function between seizures. Then non-convulsive status epilepticus, a persistent change in behavior or mental process with continuous epileptiform ECG but without major motor signs. What is the difference between these two? Convulsive and non-convulsive. This is the convulsive seizural attacks associated with persistent post-ictal depression. Here the motor involvement is not there, but persistent change in either behavior or continuous ECG changes, epileptiform changes will be present in non-convulsive stage, but there are no motor signs. Whereas in focal status epilepticus, with or without altered awareness, it can be seen focal involvement continuously it will be there. Then general supportive measures, how are you going to manage general and specific support, specific therapy? The patient's vitals, fluid, and electrolyte balance should be maintained, and measures should be taken for care of a comatose patient. Then first priority is to maintain patent airway because the patient will be landing upon in tonic-clonic seizures like general status epilepticus, continuous convulsive attacks will be there. So the patient will be like stiff, and then if the patient falls like this, the epiglottis will be like the respiratory passage will be blocked with the epiglottis. So to prevent the respiratory failure because of that attack, we need to make first the patent airway the patent. So patent airway is the first preferred thing that we need to do. Then oxygenation, then fluid and electrolyte balance, BP, and normal cardiac rhythm, euglycemia, and care of the unconscious must be taken. Then hypoglycemia and hypocalcemia must be ruled out, which may be the cause of convulsions, especially in children. But the secondary causes should be treated first. That's what we have discussed in the prescribing guidelines. Then dextrose. So if you have diagnosed that it is status epilepticus, now the treatment, actual treatment starts. The dextrose, that means pharmacotherapy. Dextrose 50 ml 50% IV, that is to be administered to combat hypoglycemia. Okay, but it has to be preceded with the administration of thiamine 100 mg IV because dextrose or glucose may precipitate vernix encephalopathy in susceptible cases, mainly chronic alcoholics. So to prevent that, you have to administer first thiamine and then dextrose to prevent vernix encephalopathy. Then Lorazepam. So we have diazepam and Lorazepam also, but we prefer Lorazepam because it is a long-acting preparation. IV 4 to 8 mg given over 1 to 2 minutes, repeated if there is no response within 5 minutes. Lorazepam has also been administered by squirting it intranasally using an atomizing pump. It reaches the brain rapidly along the peripheral neural pathways through olfactory and trigeminal nerves, bypassing the blood-brain barrier, and acts within minutes. So what are the various routes of administration of anti-epileptic drugs? You may be asked in 2 marks questions also, like oral, IV, IM, intranasal, all these things you can write down. Okay, especially Lorazepam, either IV, that is a drug of choice, or even through intranasal administration for quick action. In case Lorazepam is not available, then you have to go for IV diazepam 10 mg IV slowly. Lorazepam 4 to 8 mg IV. Here it is 10 mg IV slowly over 5 minutes and repeated later on. If IV administration is not possible, then diazepam rectally, same case 10 mg in adults. So here you can see intranasal drug delivery to the CNS in case of epilepsy also. This is one olfactory pathway and this is respiratory pathway. That is, we are not going to discuss this respiratory pathway. So through trigeminal nerve and through olfactory nerve. So they both cross the blood-brain, skip the blood-brain barrier and directly enter into the brain. So that is the advantage of this route of administration. That is, we have discussed intranasal route of administration using an atomizing pump. Then diazepam though has a longer half-life. Why we are not using? Why we want to choose Lorazepam? This may be a reasoning type of 2 marks question for undergraduates. Because even though diazepam molecule has longer half-life, it has a higher volume of distribution and more lipid solubility. Hence, the therapeutic effects are of short duration than those of Lorazepam, which is having 2 to 8 hours long action. So Lorazepam is preferred over diazepam because of longer duration of action, even though both are having same kind of efficacy. So because it is long acting. For prolonged effect, Lorazepam or diazepam should be immediately followed by, even though Lorazepam is long acting, to produce further prolonged effect, we need to add further IV phenytoin sodium loading dose, that is 15 to 20 mg per kg at not more than 50 mg per minute. Then phenytoin should not be diluted in glucose solution as it precipitates. So this point we have discussed in the conventional anti-epileptic drugs. So Lorazepam preferable more than diazepam. So IV route and then intranasal route. And if it is not available, diazepam IV route. If it is not available in case of children, rectal route of administration. Then to have a sustained effect, we can go for IV phenytoin sodium. Okay, but it should not be diluted in glucose. Then hypotension and respiratory depression should be watched for, especially in patients who have received barbiturates earlier. So there is more profound respiratory or cardiac arrest may happen because of it. So it is most commonly seen with the IV diazepam. So that's why we are administering diazepam IV slowly. That is the reason. Why slowly means there is a risk of cardiac arrest or respiratory arrest. Then in the pre-hospital setting, rectal diazepam, we have discussed that intranasal midazolam or buccal midazolam are acceptable alternative first treatments if the preferred options are not available. So we have discussed like oral route, IV route, IM route, intranasal route. Now what are the routes? Other routes that we are getting? Buccal route also. For midazolam, there is intranasal route or buccal route also. For lorazepam, IV route and intranasal route. Then fosphenytoin 100 to 150 milligrams per minute IV infusion to a maximum of 1000 mg. ECG need to be monitored. This may suppress seizures that have not responded to lorazepam. So it can give better long-term seizure control. Then levetiracetam 50 mg per kg IV 100 mg per minute may be used if phenytoin or fosphenytoin is contraindicated or if the seizures are not controlled. Then phenobarbital sodium 50 to 100 mg per minute IV, maximum of 10 mg per kg. It is an alternative to fosphenytoin or when there is no response with fosphenytoin. It is also employed to maintain seizure-free state over short term before definitive oral therapy is instituted, just before switching over to the oral therapy. Phenobarbital is also an acceptable second therapy, but it has a long half-life causing persistent side effects, including severe sedation, respiratory depression, and hypotension. So you need to see the condition of the patient and then you have to select whether phenobarbital can be administered to that particular patient or not because of this dreadful area. Then lorazepam, fosphenytoin, midazolam, and rarely phenobarbital can also be used by IM route. All these drugs can be used even by IM route if IV route is not possible due to any reason or difficulty, such as in case of children or infants. An alternative is clonazepam 1 mg IV, repeated if necessary. Still, if the seizures persist, intubate the patient, institute IV sodium valproate, which is having multiple actions. If seizures still persist, IV general anesthesia is administered with a short-acting barbiturate in consultation with an anesthesiologist. That is, propofol or midazolam can be administered at the last stage if you don't get any response with IV sodium valproate E1. Refractory cases who fail to respond to even lorazepam and fosphenytoin within 40 minutes of seizure onset may be treated with IV either midazolam, propofol, or thiopentone anesthesia with or without curarization and full intensive care. So this is the last resort for refractory cases. Lignocaine IV can be used in resistant cases, but it must be remembered that lignocaine itself can induce convulsions. So after adequate amount of anti-epileptic drugs, that is like phenytoin or phenobarbital therapy, and then some amount of response that you can get, then only it is the last resort you can think about lignocaine. Where facilities for intubation or resuscitation are not available. So last resort, we have thought about the intubation with few drugs. So if intubation is not available, you are working in like a peripheral healthcare center or at somebody's home, nearer, you don't have any intubation support, then you can directly go for phenobarbital IV at a similar rate to total dose of 800 milligram phenobarbital or 200 mg IM repeated as necessary, or paraldehyde deep IM, that is 5 ml in each buttock, 2 injections can be given, or paraldehyde, even rectal administration is preferable. Okay, so this is how you are going to manage the patient. Rectal paraldehyde causes little respiratory depression and thus can be used when where facilities for resuscitation are lacking. Okay, Then lacosamide is available in an intravenous formulation we have discussed in the newer drugs. But there is little published experience to assess the efficacy. If the second therapy fails to stop the seizures, then additional second-line agent is often tried. So, then patients in status epilepticus are liable to develop hyperpyrexia. It should be looked for and treated. So, the supportive management that I'm discussing about now. Then between convulsions, a soft object such as a folded napkin should be inserted between jaws here in the mouth to prevent tongue biting during convulsions, otherwise tongue may get cut off. Then immediately on recovery, the patient should be switched over to oral anti-epileptic drug therapy. So the summary of the status epilepticus is a very, very, very important question for both postgraduates and undergraduates. For Viva, even every candidate may be asked regarding the status epilepticus, status asthmaticus, both the things. So what are the drugs used in order? Lorazepam IV, 4 to 8 mg because of long-acting nature. Diazepam, if that is not available, then go ahead with diazepam 10 mg IV rectally or even like IV or rectal or intranasal midazolam or buccal midazolam. Then phenytoin sodium IV, fosphenytoin or phenobarbital sodium or clonazepam or levetiracetam. That is a second line drug. Then if seizures persist, intubate the patient with IV sodium valproate. Still no response, IV general anesthesia with propofol or midazolam. Then if intubation supportive measures, support is not available, then go ahead with IV phenobarbital or paraldehyde deep IM or rectal. And in case of refractory cases, IV midazolam or propofol or thiopentone anesthesia with or without curarization and full intensive care. This is how the pharmacotherapy of status epilepticus goes. Then refractory status epilepticus. This occurs when seizures continue or recur at least 30 minutes after treatment with first and second therapy agents. So again and again. Occurs on discontinuation of general anesthetics. We are putting the patient on general anesthetics at the end stage, and if we discontinue, then again the status epilepticus recurs and it may land upon in refractory status epilepticus. So treatment is because of the discontinuation of general anesthetics, we have to again treat the patient with anesthetic doses of pentobarbital, propofol, midazolam or thiopentol, and even sometimes ketamine is also effective. Then absence status epilepticus. So we have discussed various types of epilepsies, right? This is second one, that is absence status epilepticus. Prolonged generalized absence seizure that usually lasts for hours or even days. So there is no convulsion, motor movements are not there in this. But prolonged generalized absence seizures are there that usually last for hours or even days. Okay. It can occur when an inappropriate anti-seizure drug such as tiagabine or carbamazepine is used in a patient with idiopathic generalized epilepsy. So here what happens? Generalized absence seizures. Absence seizures means there is no motor involvement. You remember petit mal epilepsy or absence epilepsy. Motor involvement is not there, but it is a convulsion like blinking of the eyes, all these kinds of things will happen. So treated by IV benzodiazepines like lorazepam or diazepam, followed by IV sodium valproate or oral or nasogastric ethosuximide. Then focal status epilepticus, that is the third variety. Treatment is similar to therapy for convulsive status epilepticus. So if you get a question like this, treatment of focal status epilepticus, you can write the same thing. Then what are seizure clusters? Acute repetitive seizures or seizure clusters. These are a group of seizures that occur more frequently than the patient's habitual frequency. So the difference between status epilepticus and seizure clusters is the clusters can occur rapidly over several minutes, or they may occur over a long period of 1 or 2 days even. But there is complete recovery between seizures, whereas in status epilepticus, it will be like for a period of 15 minutes to 30 minutes, but there is a recovery of complete recovery between the seizures. No, there is no complete recovery between the seizures there in status epilepticus. In seizure clusters, there is a recovery. So the patients do not meet the definition of status epilepticus. However, the condition is concerned nevertheless because in the absence of treatment, prolonged seizures or status epilepticus can occur. So if you don't treat it because the patient is like having complete recovery between the attacks, then it may land upon in status epilepticus, which is very a medical emergency. So treatment is with IV benzodiazepines or diazepam rectal gel or rectal paraldehyde, or even buccal or oromucosal midazolam. So buccal route of administration with oral syringe, then intranasal midazolam, diazepam or lorazepam. Then other types of epilepsies management. Emergency management of convulsions due to other disorders like withdrawal of sedatives, including barbiturates, tetanus, eclampsia, cerebral hemorrhage, poisoning from convulsive agents during administration of local anesthetic similar to that of status epilepticus. All these conditions also may give like epileptic convulsions. The drug of choice for such cases is diazepam or lorazepam is the drug of choice, and paraldehyde IM also can be used. Then mixed seizures, both tonic-clonic and absence seizures combination. Sodium valproate is the drug of choice. And then most of the drugs used for grand mal epilepsy, mainly carbamazepine and phenytoin, exacerbate the petit mal epilepsy. And ethosuximide and clonazepam worsen grand mal epilepsy. See, so most of the drugs used for grand mal epilepsy, especially carbamazepine and phenytoin, they can exacerbate petit mal. And ethosuximide and clonazepam can exacerbate grand mal epilepsy. So when there is a combination of both the things, the drug of choice is sodium valproate. So don't write the treatment of choice like grand mal epilepsy drugs plus petit mal epilepsy drugs. No, they may like when you combine, they may exacerbate each other. So the drug of choice here is sodium valproate. Okay. Then myoclonic drugs. Sodium valproate is the drug of choice. In majority of the conditions, sodium valproate is like the drug of choice. Clonazepam and nitrazepam are alternative drugs. Focal seizures. Treatment of this condition is similar to that of grand mal epilepsy. Seizures are often refractory to drug therapy. So preferred drugs are carbamazepine and phenytoin. And post-traumatic seizures because of head injury. So treatment is prophylactic with phenobarbital, carbamazepine or phenytoin. Then atonic seizures are akinetic seizures. Sodium valproate again drug of choice. Otherwise, we can go ahead with benzodiazepines, lamotrigine and clonazepam. And juvenile myoclonic epilepsy, it's like incidence is 10% of all epilepsies. Sodium valproate again drug of choice. Other alternative drugs can be used are clonazepam, lorazepam, lamotrigine, levetiracetam, topiramate, and zonisamide. Then childhood absence epilepsy and juvenile absence epilepsy. Childhood absence epilepsy means between 4 to 8 years. Juvenile absence epilepsy means 6 to 10 years age. So there are mainly absence seizures in childhood absence epilepsy, but occasionally tonic-clonic seizures. Whereas in case of juvenile absence epilepsy, when the child grows a little bit further, like 4 to 8 years and 6 to 10 years, so here the tonic-clonic seizures are more frequent and absence seizures are little less. So this is the main difference between those two. So childhood absence epilepsy, ethosuximide and sodium valproate. And for juvenile absence epilepsy, sodium valproate and lamotrigine. So this is the main table which you can recollect all the drugs. Tonic-clonic seizures, valproic acid, carbamazepine, phenytoin. Alternative agents are phenobarbital, adrenaline, newer anti-epileptic drugs like lamotrigine and topiramate. And this is I don't remember what is this. It is not visible here. So okay, we'll skip this one. Absence seizures, ethosuximide and valproic acid. Then the alternative agents are clonazepam, and then lamotrigine, levetiracetam, and zonisamide. Myoclonic and atypical syndromes, valproic acid, clonazepam, and alternative drugs are levetiracetam, topiramate, and then zonisamide. And the newer drugs are lamotrigine and felbamate. Status epilepticus, diazepam, lorazepam, phenytoin, phenobarbital. So many drugs we discussed just now. Okay. Then other few rare types of epilepsies we are going to discuss, just few. Lennox-Gastaut syndrome starts in childhood. Features are frequent seizures with the multiple types of seizures, that is tonic seizures, clonic seizures, tonic-clonic seizures, absence seizures, myoclonic seizures accompanied by impaired cognitive function and mental retardation, that is Lennox-Gastaut syndrome. Okay, how are you going to treat this? So this is difficult to treat and often multiple drugs are used. Even the prognosis is poor because of underlying CNS disease. Sodium valproate is the drug of choice. Other drugs used are lamotrigine and topiramate. Sodium valproate is a drug of choice, of course, for many epilepsies. So here the other drugs effective are Lanax, L and T, lamotrigine and topiramate. And the other drugs used are clobazam, rufinamide, fluorophilbamate and felbamate. Then Dravet syndrome. Severe myoclonic epilepsy of infancy, rare genetic type of epileptic encephalopathy presented as diverse generalized and focal seizures. Drugs use TCS for stiripentol, which is highly effective, and second highly effective is T for topiramate. Apart from that, we can use clobazam and sodium valproate. Then sodium channel blocker anti-epileptic drugs worsen this kind of epilepsy and thus are contraindicated. It's a point to be noted here. So here one thing I would like to tell you after discussing about all these drugs, PG students may get in final exam the questions like drugs acting through sodium channels. So not only the anti-epileptic drugs, wherever the sodium channel blockers are there, or even agonists are there, whatever it may be. So sodium drugs acting through sodium channels, calcium channels, potassium channels, all these things can be your 10 marks question for postgraduate. So be aware and prepare notes for that. Then mesial temporal lobe epilepsy, that is like mesial surgical. So only therapy that is available is surgical therapy because it is highly resistant to drug therapy. Features are complex partial seizures with characteristic clinical, pathological, and ECG changes. Most common epileptic syndrome, mainly due to hippocampal sclerosis, diagnosed by high resolution MRI. Then neonatal seizures, seizures occurring in neonates 2 to 3 days immediately after birth. One of the important causes is pyridoxine deficiency. So we have discussed in the introduction to CNS that vitamin B6 or pyridoxine acts as a cofactor in the synthesis of GABA. So pyridoxine deficiency or vitamin B6 deficiency, GABA synthesis is not adequate. So adequate anti-epileptic, endogenous anti-epileptic activity is not seen. So because of which neonatal seizures may be a predominant effect that could be seen in such children. So the treatment is supplementation of pyridoxine. Then West syndrome, WS. It is not here, the mnemonic, you can take it like W means you just take half of this W, that is V. V for Vigabatrin, and zonisamide and nitrozepam are also other active drugs. And S for steroids, specifically prednisolone is used in this type of epilepsy and also ACTH. So this epilepsy, West syndrome occurs in infants and there is intermittent skeletal muscle spasm, maybe generalized tonic-clonic convulsions of short duration with progressive mental deterioration. Okay, it's refractory to anti-epileptic drugs. Then catamenial epilepsy, we have just now discussed, the epilepsy which increases during menses. So it is because of the effect of hormone estrogen and progesterone. Okay, or due to reduced plasma concentration of anti-epileptic drugs because of altered plasma protein binding. So you have to treat the patient with acetazolamide. I have just elaborated the letter. The size I have increased. So A for acetazolamide administration, that is 250 to 500 mg per day. 7 to 10 days, 1 week or 10 days before the onset of the menstruation till the menses completes. So that is one thing. It is because of either reduced plasma concentration of anti-epileptic drugs or the effect of estrogen or progesterone. So alternatively, increasing the dose of anti-epileptic drug or administration of progesterone or use of oral contraceptives to regulate the menses can be tried, because oral contraceptives combined pills can contain both estrogen and progesterone. Okay. Then Galoxone is also effective. Ganaxolone, not Galoxone. Then non-epileptic uses of anti-epileptic drugs. Carbamazepine is used. This is a very, very important question for both PGs and UGs also. UGs may get like 2 marks question. Carbamazepine for trigeminal neuralgia and bipolar disorder, and phenytoin also. Lamotrigine for neuropathic pain syndrome, gabapentin for neuropathic pain syndrome, migraine, spasticity, and social phobia. Pregabalin also, of course. Topiramate for migraine, essential tremors, and binge disorder. I'm not going to tell what is binge disorder. This is homework for you. Then sodium valproate for migraine and bipolar disorder, diazepam and oxazepam for anxiety neurosis. Okay. So many drugs for migraine. So this can be a possible question for Viva OC. Anti-epileptic drugs which are used in the management of migraine. 2 marks question. Then primidone for essential tremors, vigabatrin for spasticity, phenytoin for digoxin-induced ventricular tachycardia, phenobarbital for neonatal hyperbilirubinemia, carbamazepine or sodium valproate for the treatment and even prophylaxis of mania as a second choice drug to lithium, and newer anti-epileptic that's useful for mania or lamotrigine, topiramate, and gabapentin. So the anti-epileptic drugs which are used for the mania, that is another 2 marks question. Then resistant epilepsy, if pharmacoresistant epilepsy, if like all these drugs still after putting all these drugs, the patient is not responding, then it is referred to as pharmacoresistant epilepsy. Okay, so the basis is not well understood, but we have the only option that is left over, that is surgical therapies and electronic devices. Surgical therapy is like a resection of the affected brain region, that is like, for example, temporal lobe resection for mesial temporal lobe epilepsy, and extratemporal cortical resection, that is lesionectomy, in case the seizures arise from cortical injury, malformation, or tumor, or a vascular lesion. So other surgical measures that are available for this resistant variety of epilepsy are temporal lobe resection, apart from lesionectomy. Others are functional hemispherectomy, corpus callosotomy, and extratemporal cortical resection. Then, apart from the surgical resection, we have electrical stimulation devices also. That is, we have 3. That is, number 1 is vagal nervous stimulator. It is an implanted programmable pulse generator with a helical electrode that is wrapped around the left vagus nerve in the neck. So it is like a non-invasive in one way, we can say. It is not completely invasive method. The device which continuously delivers open loop, this is open loop, it is not invasive completely. So open loop stimulation according to a duty cycle is approved for the treatment of drug refractory focal seizures, but may also be a good option for symptomatic or cryptogenic generalized epilepsies such as Lennox-Gastaut syndrome, including with intractable atomic seizures. So in these conditions, you are going to go for, if it is resistant, not generally it is resistant only. So that's what we have discussed when we were discussing about Lennox-Gastaut syndrome. We have drugs, but generally it is not responding to the pharmacotherapy. So we have to go for electrical stimulation device, that is vagus nerve stimulator. So you can see in this diagram. So left vagus, this is stimulated. So inhibitory response that we can give with electrodes. So pulse generator is, it is controlled here at the level of the left clavicle. So it sends tiny electric shocks to vagal nerve. So through this pulse generator. So programmable generator lives with 2 coils and handheld magnet. These are the 3 parts available. So these chips, here one. So they monitor electrical activity from 64 electrodes in the brain while delivering electrical stimulation to prevent seizures or tremors. So this is one thing, and this is another thing. This is like a kind of non-invasive. This is a kind of invasive technique. So chip is inserted there, here in the brain also. Then resistant epilepsy, another modality of electrical stimulation, that is responsive neurostimulator. It is a closed loop. It is completely invasive technique that detects a pattern of abnormal electrical activity in the seizure focus and then delivers electrical stimulation to prevent seizure occurrence. So where exactly the focus of seizure is there, how much it is like releasing the firing of the potential, seizure neuronal firing frequency is there. Based on that, that is inhibited because of electrical stimulation. Then deep brain stimulation device, it is approved in Canada and Europe, but not in USA. So here you can see RNS system, cranially implanted battery here, power response neurostimulator, connected to 2 leads, okay, with 4 electrode contacts. Here you can see RNS device is surgically implanted here within the brain, in the skull, and is designed to prevent or halt seizures. So we have the electrical, this is burr hole, and then we have to insert within the under the skull in the brain, and we need to modulate it through the battery. So deep brain stimulation, it is used to help control tremors or epilepsies, seizures, anything, or chronic movement disorders. Tiny electrodes are inserted surgically or that is implanted within the brain and are connected by a subcutaneous wire to a neurostimulator near the left clavicle under the skin. So here we are going to control. So stimulation, release, and then it is going to control the focal seizures. Then last one, that is epilepsy and pregnancy and even breastfeeding. So what happens when we use, whether to use or not, when we use, what happens? Normal incidence of teratogenic effect, that is congenital abnormalities, are found in about 2 to 4% cases as compared to 4 to 8% in pregnant women on anti-epileptic drugs. That is twofold increased risk as compared to non-epileptic mothers. So generally we come across congenital malformations in normal mothers. And we do come across the same congenital malformations in epileptic mothers also. So the incidence between this group and this group is just 2% increase. So even if you don't give anti-epileptic drug administration also, there is a possibility in the world. So we need to think about the benefit versus risk. If we don't administer, there is a preponderance of the seizure attacks, because of which there is a possibility of termination of the pregnancy or abortion even. It is dreadful to the fetus. So risk of seizure is reduced during pregnancy itself due to progesterone that maintains the pregnancy. But still some cases it fails, of course. Anti-seizure medications increase the metabolism of hormonal contraceptives. So why there is when the patient is on anti-epileptics, why there is a risk of pregnancy? Means this is the enzyme induction effect. So you have one clinical problem exercise also based on this. Potentially rendering them ineffective, that is phenytoin, phenobarbital, carbamazepine, topiramate, oxcarbazepine, rufinamide, and clobazam. All these, they fail the role of efficacy of hormonal contraceptives. That is why there is a risk of pregnancy in patients. So we need to think about, we should not prescribe enzyme inducers to the ladies who want to plan a pregnancy. Okay. These medications increase the metabolism of contraceptives regardless of the delivery system use. It is not just oral. So even if you give these hormonal preparations through patch or ring or implants or oral tablets, whatever may be the route of administration, there is a possibility of contraceptive failure and further pregnancy results. Over 90% of women taking AED give birth to healthy babies, and pregnancy need not be terminated in well-controlled epileptics. So it does not mean that all mothers who are on anti-epileptic drugs, they will give rise to 100% malformed babies. It is not so. So majority of the ladies can give, that is like 90% women can give healthy birth to healthy babies. The consequences of uncontrolled seizures are more deleterious than the effect of anti-epileptic drugs. That's what we discussed just now. And the pregnancy should be continued with appropriate anti-epileptic drugs. Sudden cessation of anti-epileptic drugs precipitates status epilepticus and consequently abortion. Hence, anti-epileptic drugs should not be stopped abruptly during pregnancy. Their dose can be reduced to a little bit less. Anti-seizure drugs increase incidence of birth defects, but epilepsy in pregnancy. So what is the risk with this? Increased birth defects. So this is possible with both cases, but only epilepsy in pregnancy, but no anti-epileptic drug uses. There is an added risk of the baby is born with mental retardation because of anaxia during seizures, toxemia, intrapartum hemorrhage, and premature labor. So better to put the patient on anti-epileptic drugs. The major fetal malformations with AEDs are cardiac defects, cleft palate, neural tube defects, and spina bifida. Minor are nail hypoplasia, low set ears, and prominent lips. Then all the conventional drugs, that is like sodium valproate, phenobarbital, phenytoin, and carbamazepine are teratogenic. So all the drugs are teratogenic. Sodium valproate has the highest teratogenic effect, whereas the carbamazepine and especially oxcarbazepine has the least teratogenic potential, which can be preferred in pregnancy. Then anti-seizure drugs increase. So yeah, this we have finished. Anti-epileptic drugs, which are enzyme inducers, lower the maternal plasma levels of vitamin K, leading to postpartum hemorrhage. This we have discussed in the introduction to AEDs. Hence, oral vitamin K need to be administered just last 2 weeks of pregnancy. Apart from that, prophylactic folic acid supplementation 5 mg per day in second and third trimester along with vitamin K in the last month of pregnancy is recommended to minimize the neural tube defects, that is especially spina bifida and anencephaly. And along with that, bleeding disorder to be prevented with vitamin K administration in the last 2 weeks. Then what are the specific AEDs induced teratogenic effects? This is YYOC question for both UGs and PGs as well. Valproate, neural tube defect or spina bifida, phenobarbital cardiac defects, topiramate oligohydramnias, jonisamide also the same thing. And topiramate in addition produces oral clefts. Valproate, phenobarbital, topiramate, they should be avoided in women of childbearing potential or used at the lowest dose because it is having the highest risk of teratogenicity. Then carbamazepine and levetiracetam, risk of congenital malformation is less but not zero. So somewhat safer in pregnancy. So it is when it is needed, then you can opt these 2 molecules and even oxcarbazepine. Then, in addition to congenital malformations, there is evidence that the first trimester exposure with AEDs is associated with cognitive impairment. This is very, very important. So, valproate has highest risk of cognitive impairment, whereas lamotrigine or levetiracetam safer in regards to the cognition impairment and lower risk of congenital malformations. So, these are the safest molecules. Teratogenic rank order of various anti-seizure drugs: trimethadone, valproic acid, then phenytoin, phenobarbital, primidone, carbamazepine, oxcarbazepine, topiramate, lamotrigine, and ethosuxime. So carbamazepine, oxcarbazepine, lamotrigine, and ethosuximide, safest anti-epileptic drugs, somewhat when compared to the other drugs during pregnancy. AEDs, then what about breastfeeding? The last slide. AED can be used safely during breastfeeding. Primidone, gabapentin, lamotrigine, topiramate, and levetiracetam readily enter into breast milk and thus should be avoided during lactation. But AEDs with high plasma protein binding such as phenobarbital, phenytoin, carbamazepine, and sodium valproate do not enter breast milk and thus safer during lactation. So both are different. Safer drugs during pregnancy and safer drugs during breastfeeding, both groups are different. So here you can go for sodium valproate. There it is highly risky in pregnancy. Then sedation may occur with phenobarbital in breastfed babies, but by and large, no significant effect is reported. Though anti-epileptic drugs are secreted through breast milk to some extent, the risk-benefit ratio favors breastfeeding to continue while taking anti-epileptic drugs. So you need not ask the mother to stop the breastfeeding totally. So, okay. So this is the point to be noted. So thank you one and all for your patient listening. So don't feel that why madam has released 4 sessions. So it is going to be useful throughout your life. All the clinical implications and therapeutic aspects I have discussed in detail because I don't have any restriction of time for online classes. So here with this session, I end this anti-epileptic drugs. Then only 2 more sessions are pending for me because of my ill health. I could not do it at a faster pace. That is like opioid analgesics and antagonists. Only 2 sessions I'm going to release because there are no much of drugs there. So please go through all these sessions. So don't keep pending. You may have anytime the first internal assessment. Thank you. Thank you one and all.